צהריים טובים, זהו המושב על המקום של טכנולוגיה זעיר פולשנית בטיפול בחולים. רוצים להודות איתי עמית סגב מתל השומר ומזכ"ל האיגוד, אני מיכאל גליקסון. אנחנו קודם כל רוצים להודות לחברת מטרוניק שאפשרה את קיום המושב הזה, ולהודות למרצים שאתם תפגשו עוד מעט. הדרך שבה נעשה את זה 4 הרצאות של רבע שעה כל אחת. בתום 4 הרצאות תוגש מנה עיקרית ובמקביל יישאלו השאלות. אנחנו נקיים את הסשן בעברית, חוץ מהאינטרודקשן של המרצים הזרים שאותם נציג בשפתם, באנגלית. So we'll start with the first presentation. I would like to call on Dr. Loftus from St. George in London, UK. Dr. Loftus will update us on the place of minimal invasive technologies in optimizing outcomes for the endovascular repair of type B dissection.
Thank you, Chairman. Ladies and gentlemen, thank you to Medtronic for asking me to come and speak in this lunchtime symposium and enjoy a bit of the sunshine away from London. This is a controversial area, and I'm sure there'll be varied opinions in the room as to the role of endovascular techniques in dissection. I hope I'll give you a balance to you and touch on some of the particular controversies. So, the particular area we're most interested in endovascular techniques is treating complicated dissection, type B dissection, because we know it's very high risk. So left untreated, a significant proportion die. And the complicated forms of type B dissection, I'm sure you all know well, and I've just listed them there. So early intervention is key, really, in preventing both early and late mortality. And there is debate about the role of medical or conservative therapy for uncomplicated, which I'll touch on again towards the end of my talk. So endovascular techniques, and I apologise, this isn't a Medtronic stent, but just to give you a balance to endovascular techniques to treat dissection are a fairly simple concept. The concept is, in a complicated dissection, to get up the true lumen with a stent graft, which can be placed over the primary entry tear, which is usually relatively close to the left subclavian artery, and by simply covering that major entry tear and preventing continued high-pressure perfusion of the false lumen, hopefully you prevent long-term complications associated with the dissection, in particular long-term aortic dilatation. So the concept is a simple one. This is just to show it in action. I know this doesn't show very well, but this just shows you there. Sorry to put you off your lunch with a bit of blood. This is a percutaneous technique, single groin access of the femoral artery, and this is the Medtronic Captivia device in action. The device deployment is a very simple one. The key is ensuring you're in the true lumen and getting good imaging of the proximal arch vessels to enable accurate positioning of your stent graft. And these newer generation of thoracic devices are extremely accurate in terms of deployment into the arch of the aorta. Here you'll just see this is having imaged the arch of the aorta. We saw the entry tear just distal to where I'm deploying the stent here. I've seen the arch branches that are safe. And here we are deploying these. This is a simple, for those of you not used to this device, it's a very simple mechanism, which is essentially a turning handle on the delivery device up through the groin. And you see the stent being deployed. Here is the outer sheath of the delivery device being pulled back, the stent being deployed. And at this stage, this is still held in the delivery device through a nose cone here, which holds a proximal bare stent. And that enables very accurate positioning of this at the last minute with release of the bare stent as shown there. The delivery device is then brought back and resheathed, and further stent grafts can be placed down the aorta as far as one needs to go to ensure a complete sealing of the dissection and a complete resolution of what you're trying to seal. So, as I say, conceptually, this is a relatively easy technique. And early results, this is by far the largest published series. Early results show a significant advantage for endovascular techniques over open repair. This was a very large series from the United States, published in the Journal of Vascular Surgery. And for all type B dissections, those that underwent TEVAR, and this is well over 1,000 patients, the mortality was halved compared to open repair. That's despite this group being much sicker and much older. So it does seem safer than open. I would say safer. Still not necessarily safe, it's still a high-risk procedure. So I'm going to touch on a few of these rather controversial issues and particularly some technical aspects to try and improve the outcomes. So again, it's still stressed there are still risks of mortality and neurological complications associated with this. I'm going to touch on some aspects of timing of intervention related to balancing the need for aortic remodeling against the risk of the intervention itself, some longer term outcomes, and then finally touch on the role of endovascular therapy in uncomplicated dissection. Much of what I'm going to present to you is based on evidence from the Mother Registry. This is the Medtronic Thoracic Endovascular Registry, which is a composite of a number of clinical trials and other registries, plus our St George's experience of well over 200 cases. And that's giving us long-term prospective data collection on well over 1,000 cases with adjudicated adverse events, 5-year outcome data, and the ability to do subgroup analysis to look at some very specific outcomes. I won't bore you with all of these demographics, but just to highlight the numbers. So in this group of over 1,670 for aneurysmal disease and dissections just over 300, of which 114 are acute. And the only thing to note is, as you might expect, the dissection groups are younger, with an average age of around the 60 mark, and they are less comorbid than those with aneurysmal disease, and that's as one would expect. So one of the things I'm going to touch on first is coverage of left subclavian artery, because often when we're treating with endovascular techniques, we cover the left subclavian artery with our stent grafts, and traditionally we've done bypass grafts to try and prevent the complications that have been associated with coverage of the left subclavian. On the basis of the supposed hypothetical complications associated with coverage, Medtronic have now developed a branch graft for deployment into the left subclavian artery, and I just show this cartoon to highlight it. This isn't widely available yet, but will potentially become a useful technique for arch, aneurysmal and dissection cases. This essentially has a preloaded wire, as shown here, which is snared into the left subclavian artery from arm access, and you see the small branch on this thoracic device, which is placed directly into the left subclavian as shown. And the procedure is simply completed with a small covered balloon expandable stent placed up from the arm access. So I'm only touching on that as an innovation, which may be very useful in the future. So where are we with management of the left subclavian? I go back to the Mother Registry database to show you some evidence, and again you'll see that the risks associated with thoracic endografting are still reasonable. So there is a risk of death, there's a risk of stroke and a risk of spinal cord ischemia. But one of the major factors in terms of stroke risk is this coverage of left subclavian artery. So if you don't go near it with your stent graft, your stroke risk is low, 2%. If you cover it, that's fivefold, 9%. If you revascularize it, you halve it back down to less than 5%. So coverage of the left subclavian does seem very important. However, when we picked apart the registry data to look at dissections, and these graphs show essentially the light blue are those cases that are thoracic aneurysmal disease, the dark blue are dissection, with the middle group are the covered, the right-hand group revascularized, you'll see there was absolutely no difference in the dissection group. So the advantage of revascularizing the left subclavian artery is only really seen in those patients with aneurysmal disease and not dissection. The second complication we particularly worry about with thoracic endografting in dissection is retrograde type A dissection. If any of you have seen this following endografting, it can be a devastating complication as shown in these pictures. It's perhaps not surprising. You see in these functional imaging just how fragile the aorta is when you have a dissection, and it's perhaps not surprising putting stiff wires and large delivery devices through this that you may cause some trauma. So what are the causes of retrograde type A? Well, we've tried to look at this with a systematic review. This was recently published in Annals of Surgery and incorporates the Mother Registry data along with other reports approaching 10,000 cases. And the overall incidence is actually relatively low, 1.7%. But if you get it, it's bad. A third of the patients will die. And what causes it? Well, the first thing that causes it is if you have a dissection. Again, that's perhaps not surprising. So it's disease specific. If you have an acute dissection, you have an 8.4% risk of a retrograde type A dissection, and that's much lower in chronic dissections and thoracic aneurysmal disease. So clearly patients with acute dissection are at higher risk. Furthermore, the further round the arch of the aorta you have to go to treat the disease, and these are landing zones 0 past the innominate artery down to 3 or 4 past the left subclavian. Again, the risk becomes significantly higher the closer you go to the aortic valve. And finally, the issue of endograft configuration has been a hot topic for a number of years, with companies accusing each other of causing this through the design of their stent grafts. And this pretty much lays that argument to rest and essentially shows that the configuration of the stent graft makes absolutely no difference to the incidence of retrograde type A dissection. And within the mother registry database of 1,000 cases, the rate is 1.6%, exactly the same as across the entire literature with all other devices. The most important factor we found is actually the oversizing of the endograft. So these grafts are sized slightly larger than the aorta itself to enable for good sealing and fixation. And this graph is slightly confusing, but the dotted line are those cases within the registry that had retrograde type A dissection and show the oversizing percentage compared to the native aorta, compared to those without retrograde type A. And essentially, the more you oversize, the higher your risk of causing trauma to the aorta. So in terms of reducing complications that are associated with endograft, we know in dissection you can ignore the left subclavian artery. You do not have to revascularize it. The dreaded complication of retrograde type A is independent of what stent graft you use and is not related to bare springs, but is associated with graft oversizing. And that's easy to change in clinical practice. So now I'm going to touch on some of the longer term outcomes. And again, the registry that we now have is particularly useful in looking at some of the aspects of acute, subacute and chronic dissections. And I'm going to touch particularly on the timing of intervention, which seems to be key to getting the optimum results from intervention. And I'll then also touch again on uncomplicated dissection because it's very topical. So if we look at the mother registry and look at aortic-related mortality, the red bar is the acute dissections. And you'll see that if you survive your dissection and you survive your operation, actually your aortic-related mortality out to 6 years is 0. In terms of chronic dissections, again, it's actually much safer. This is the green bar, but you do have a steady but small defined risk of aortic-related mortality going out to the long term. So acute dissection has much higher risk than chronic, but if you survive the operation, you're highly less likely to need intervention or have an aortic complication. But this touches on the timing. So can you reduce the complications associated with acute intervention to get them down to nearer those of chronic? And I'm going to show you some data from the Virtue Registry, again sponsored by Medtronic, which shows that you probably can. So this specifically picked a subgroup of subacute type B dissection from 2 weeks out to 3 months. And if you look at this group, the mortality was 0, the stroke risk was 0, and in both cases significantly lower than intervention for acute dissection, and very similar to that for chronic dissection. So that suggests it's safe, if you can clinically, to wait 2 weeks before you intervene. If you then follow this out to the very long term, and again there's slightly confusing these graphs, but the thing to look at is the red bar, which is the subacute dissections compared to the blue, which is acute. And you'll see again that the dissection-related mortality is 0 at the time of the procedure, but is maintained out to time. So actually you're still very unlikely to get an aortic-related complication out to 6 years. Similarly for aortic-related interventions, this is a very similar graph that shows that essentially the subacutes behave much better in terms of aortic-related interventions, so need far fewer interventions to maintain that low aortic-related mortality. And there's just 2 slides just to highlight this in terms of aortic remodeling. So what we're trying to achieve in endografting is to allow the aorta to remodel and go back to as normal as it can do. And 2 ways of looking at this are the true lumen and false lumen diameters. This graph shows the true lumen diameter out to 3 years in the acute, chronic and subacute group. And the key is to look again at the red and the blue, the acute and subacute. And you'll see that the true lumen areas behave exactly the same. So you get the same level of aortic remodeling in subacute as you do acute, and much better than chronic. And false lumen is identical. Again, if you look out to 3 years, the blue and the red bars show very similar remodeling in terms of false lumen change. So again, this shows that if you can wait 2 weeks, you get the advantage of reduced mortality, but the same level of remodeling of the aorta. So in terms of outcomes, we know TEVAR gives good protection from aortic-related death. There is a very high reintervention rate for chronic dissections, and we have to maximise our coverage at the time. But of importance, there is a therapeutic window after 2 weeks, which, if clinically appropriate, seems to be much safer in terms of treatment of patients, but is at a time when the aorta still remodels sufficiently to prevent long-term complications. So that leads me just to finish off to touch on uncomplicated dissections, because it is controversial, and the INSTEAD trial tried to answer the question of whether we should or shouldn't intervene using endovascular techniques. This was a multi-centre trial randomising 140 patients to optimal medical therapy or early endovascular intervention. And I stress these are all subacute or chronic, so none of these were intervened on early. And if we look at the outcomes, this was really the headline, which essentially showed no difference out to 2 years. This was the publication in Circulation in 2009 that shows a small benefit from optimal medical therapy early, which is maintained out to 2 years, but is non-significant. So the headline figure was, well, there's no difference, so probably no role for thoracic endografting. But there are 2 issues that were largely ignored in the publication. Firstly is intervention at the time of the dissection does come with a risk. We know that, but it was somewhat passed over in this paper. There were 2 deaths. There was 1 retrograde dissection, a stroke and 2 paraplegias. So you have to accept a 5% procedural risk against optimal therapy that seems to get people out to 2 years. But we know this trial was significantly underpowered in terms of mortality. And actually, if you did intervene with an endograft, there was a huge difference in aortic remodelling and a 20% crossover in the trial from optimal medical therapy to intervention, most of which because the aortas were dilating. So there are a lot of other stories to this underneath that headline figure of no difference. And most importantly, I'm going to leave you with these graphs, because actually these are probably the most important in guiding our clinical practice. These are the very recent long-term 5-year results from the INSTEAD trial. The blue bars represent mortality and intervention associated with those patients who had optimal medical therapy. And the top graphs are the most interesting, which show a cut-off at 2 years. So following 2 years, those that have had optimal medical therapy need interventions and start to die. And not only do they start to die, they die from aortic-related complications. So that tells us there is a problem, and there may well be a role for intervention early in these patients. So I think there is a cohort who we should think about intervening. We don't know which subgroup yet gains the most benefit, and I think it's important to recognise that early intervention still does come with a risk. But those on optimal medical therapy essentially will need lifelong surveillance if you don't intervene at the time of the dissection. So just to conclude, I've covered an awful lot, I'm afraid, but it is a big topic. I believe thoracic endografting demonstrates favourable results in all of the series now compared to open repair, but there is still a high complication rate in that very early phase. The left subclavian can be ignored, I think, in dissection, and there is a small but possibly preventable risk of retrograde type A. I do think there is a window following 14 days when cases can wait for 2 weeks when it's clinically appropriate. The results are without doubt better. And there is a group in this uncomplicated dissection that will benefit that we need to recognise and learn more about. Thank you very much.